If we want clinical research to truly be patient-centered, we've got to be sure that we're actually asking patients what we think we're asking them. And that's harder than it sounds. Before we jump in, I want to share a little bit of context for the conversation that you're about to see. I sit down with Kellee Howard. I'll let Kellee introduce herself in just a moment, but we recorded this at an annual conference in DC hosted by the Critical Path Institute, focused on clinical outcome assessments, or COAs. These are the tools that are used in clinical trials to measure how patients feel, function, and survive. I'm going to spend just a minute here level setting some terminology. Our conversation is rooted in a very specific corner of clinical research, but it's also relevant to scientists who are coming from other disciplines, people who are exploring careers adjacent to clinical research, and others who just might not think about these specific concepts every single day. Also, at the start of our conversation, Kellee and I spoke briefly about our own winding career paths and how we each ended up working at the intersection of behavioral science, clinical research, and especially for me, technology. A major part of our discussion focuses on something that Kellee and I worked on together, which is called the IMES, which is a migration error severity scale. IMES is a structured framework that was developed to identify and evaluate issues that arise when questionnaires are migrated, so from paper to electronic formats, or even between electronic systems. We developed and refined the IMES across multiple global clinical trials spanning different indications, regions, languages, and eCOA vendors to distinguish low-impact differences from errors that could affect patient understanding, cultural interpretation, and most importantly, data integrity. And this is where it really, really matters to me. Migration errors can sound really technical, really jargony, but many of them show up in language, translation, or cultural context. And when those issues go unnoticed, they can subtly or not so subtly change what a question means and whose voices are truly captured. So in some cases, if the errors are so great that that data would need to be thrown out, that means that this could exclude patients, particularly non-English speakers, even in studies that were designed to be diverse and inclusive. So for me, that's what IMES is really about, making sure that patient voices are captured as we intend and with the respect that they deserve. So I think I've given you all of the background information you need to really dig into my conversation with Kellee. We were pretty caffeinated, so didn't spend quite enough time on these aspects. But I really enjoyed sitting down and talking with Kellee, and I hope that you enjoy our conversation as much as I did.
All right. So I'm here today with Kellee Howard. We are going to explain who Kellee is in just a second, but just a reminder that our opinions are our own. So really looking forward to talking to you today, Kellee.
Me too. This is exciting. It's my first podcast.
It's your first podcast.
Yeah, it's very exciting, and I'm glad it's with you.
I'm really glad. I'm your first too. So why don't you tell us a little bit about yourself?
Oh gosh. Well, I am a proud Canadian, but have lived in the U.S. for some time, back now in Canada. But I really got into the patient-centered outcome space, oh my gosh, probably in the early mid-90s, when I didn't even know it was a field. So the first paper I ever wrote was Quality of Life in Alzheimer's Disease, a review, and I reviewed 3 papers. One was in Italian. The second paper I ever wrote was in goal attainment scaling and individualized assessment measures. So, jump 10 years, and I happenstance, force jumped my way into meeting with what I consider one of the leaders in the field, Lori Frank, who started talking to me about just a specific job, and kind of started working at a company, a small company that became quite large. And at 35, I thought, this is exactly what I want to do. I think I struggled when I was doing my education, my bachelor's, my master's. I wasn't really sure what I wanted to do. And I really envied the people who knew, like, the pharmacist or the doctor or the people who were very passionate about X, Y, and Z. And although I was passionate about the work that I was doing when I started out, and I was very grateful to the mentor who started me out, but it wasn't in this patient-centered outcome space that it was called that. So coming into this job and then reflecting back 10 years prior, thinking, it's one of those things, like, that's why I was doing what I was doing.
Right.
I'm really passionate about the patient. I'm really passionate about the patient voice and the patient experience. And this is really cool. So I was really fortunate. I got some amazing experience. I was on the ground when the guidance was coming out. I was very fortunate to be in the Chantilly, Virginia meeting. I was very fortunate to help with some projects that helped guide the final 2009 guidance, and just really see that field take off. And I was very fortunate to work at the knees of some of the great people who were pioneers in the field. It was just a really cool way to spend my day, and people would ask me what I would do, and I would start talking, and they said, "Oh, you really love it." And I was like, "Yeah, you know what? I really, really do. I may not love all the paperwork that sometimes comes along with it, but I really feel like we are able to do something, whether it's an N of 1 when you're speaking to a patient who's hearing somebody, having somebody talk to them and say, tell me more, when they're so used to condensing their concerns and healthcare issues in such a very short manner, where I'm saying, no, stop, please tell me what happened next. Mm-hmm. So having that first exposure to doing focus groups and one-on-one interviews was unbelievable, and it sort of set me up for showing how important the patient was and the patient's voice. And then, so that's the N of 1 or the N of 10, and then being able to be even a small part of a drug that differentiates itself because we're able to show a difference in symptoms or function or quality of life. And that's huge, right?
Yeah.
That can really impact a patient. And so, yeah, that's kind of where I came from.
All right. Well, and I didn't say, we're at the CPAP annual meeting, clinical outcome assessments. Is that what it's called now? Mm-hmm. And we've been reacting to a lot of the really good sessions that we've been seeing. And when we talked about having this discussion today, it was really focusing on just our interest in measuring things. Because if you measure things, you can influence them, you can do something about them.
Yeah.
And so much of what I just heard from you also is like what it goes into to develop a measurement, and making sure that that patient voice is reflected, and it's so important, and it's so important to figure out like how they're experiencing it, and then how to talk about it so that they can ask the right questions and get the right treatment from their doctors.
We're all a patient. At some
Yeah.
point in time, we're all going to be a patient. So for those people who sometimes say, but that's kind of soft science, or we really just need the biomarkers. But if a biomarker says you're getting better, but you don't feel better, are you really getting better?
Yeah.
And how is that affecting your psyche?
Yeah.
And so I think being able to measure it well is so very important. I think there could be, and I mean, obviously I don't know, but I know that there is a lot of bad measurement out there, and obviously historically, because I know that we're doing a lot of good measurement now, but I think about all the drugs that possibly could have been approved or might have worked, but got shelved because they didn't show any improvement, but maybe they weren't showing improvement in the right thing.
Right, or asking about it the right ways with patients, and then one of the first things that we got a chance to work on together, maybe we pivot to this
Okay,
too. It adds so much to what it is that we're able to do, including not just be focused on the labs, but to add the context to the lab. So we had to get here our own way, but we know that it's a lot of people like us who have this way of thinking, where if I'm going to do something, if I'm going to evaluate something, I'm going to assume that I want to measure it. Like, so let's just approach things in that way. So when we're talking about if the patients were asked the right questions, a huge part of that is it in the correct language for them? Is it using terminology that they understand? And is that occurring in a way that's consistent with the concept that has been validated as what is being measured? And
That's a mouthful, Lindsay.
Right? Like, what did I just say?
I don't know, no, but I mean, you're absolutely hitting the nail on the head, and I think we've all built our experience on getting to where we are. As you said, there's no sort of direct path.
Yeah.
We all come from various different paths, which is what I feel like this career, this path that we're on now, so unique. We all come at it from different perspectives. But having the ability to think about how we measure it and the importance of how we measure it is at the paramount of what we do. And pivoting to what you and I did is we think about developing measures in an English language, but we're not thinking about ideas and thoughts that may not be applicable to others. And yes, we pivoted and said, okay, now we need to do linguistic and cultural validation, which is so very important thinking about it early on, even when you're developing the initial items. It's not something you put off because you want to think about, is this concept going to translate well? Or culturally, is this going to be applicable in other countries? Or is this word going to be in Russian going to be too long for the platform?
Right.
I mean, there are things that you want to think about when you're thinking about developing a specific item. But also, we're measuring quality of life in some instances, but you have this concept of quality of life that is not the same as the concept of quality of life in other parts of the world.
Right.
Because the benchmark is very, very different. So we have this concept, and even though we're going to translate it, perhaps, and culturally validate it, we may be measuring a completely different concept of quality of life in another culture.
Right.
And I think, but going back to what you said, so you've ticked all these boxes, right? We've developed the good items, we've based it in the patient's voice, we've gone back to the patient, we've double checked, we've got the right response options, the recall period, and then we said, okay, now we're going to translate it. We even do that well. We do the cultural translation, we are very confident in what we have. But that's not the end, right? You think you're finished, but you're not.
Yeah.
Because then what you and I got involved in was, okay, so we've got this measure that's well translated and culturally validated, but, it sounds funny, but it's not. But, and I think if you, as an audience member or as a person listening to you, you would think, I don't understand that. That makes no sense to me. But not being able to take it from even a translated language, putting it into a platform incorrectly, switching off the response option. I mean, we had thousands of records that we had to go over because they had varying levels of errors in their translation and then in their migration. It was shocking.
And it was shocking to you. It was not shocking,
shocking to you. Shocking to me.
Because that's the type of
because
thing
I'm done.
Yes.
Generally, I'm done and I pass it on.
Right.
Yeah.
But it happens all the time, and I see it everywhere. I've seen it throughout my career. I saw it before I came into ECOA as well. And I think that because I experienced, when I was doing HIV work and we were working on developing, it was not large clinical trials. It was more community-based interventions, but we needed to measure the impact. So it's developing questionnaires, developing focus group guides, in some cases in languages that people are learning in their community, but not necessarily learning in school. So it's not only is it not necessarily feasible to find someone who can do the translation for you, the correct translation is not what the colloquial understanding. So I've sat in rooms where I'm observing this happening, and it was when I was more junior, so I'm taking notes or whatever. They're telling me what they're saying. But these are really, really painstaking processes because they really matter. And so I got to see that on the ground. And when I came into the ECOA space and I learned that for some things they don't go through a full front and back translation, or that you hear, which is, it's not supposed to happen, but it does all the time, that somebody just used Google Translate and they're hoping for the best, or we're going to start with Google Translate and then eventually we'll follow the right processes, and we're just operating at such a scale that issues are bound to happen. I love the measure that we developed, the measure to evaluate the measures.
That we force-gumped our way into.
The meta measure.
Yeah, the meta measure.
Which is maybe another name.
But no. IMES is perfect.
Is really good.
The name is really good.
We've got a publication that is under review right now. We've done a couple posters about it as well that you can find online. But because we approached this as, we might as well be systematic about it. Because if we can measure what's going on here, we're not just saying, that's a problem, fix it, but we were really able to address systematically something that we know is happening in scale, and we can do something about it. We measured it, so we can do something about it.
And I think we were so bombarded by so much material, and it took a long time to go through. And I think when you and I had that working meeting, which was probably the most productive meeting, our intention wasn't to develop a measure.
No.
Our intention, as you say, was to grade the errors that we're finding. So anything from punctuation to you know, a small word being different, just very minor things. You know, that's a one. That's okay. You don't have a problem. Yes, let's fix it, but you know, it's not going to affect your results. To let's reverse the response options. Let's change the word. Let's change the concept altogether because we think it sounds better. I mean, and that's what was shocking to me. And so for us, I think, and what we decided to do, just because again, we were trying to come up with a way to help fix these issues, but not raise the fire alarm to everything because there was too much.
Right.
And so that's where we came up with the 1 to 5.
Yep, 1 to 5.
1 to 5 scale, where we graded things. So I think it was 1 and 2, we thought, you're good, you can kind of go on. 3, it might be case dependent, and it depends upon where it's sitting in the trial. If it's primary, we're probably going to have to fix it. If it's not, let's see where we are.
What is the likelihood of impacting patient response? So like 1 and 2 were, the patient might judge us because there are typos,
or
it's
spelled wrong
graded
or something like that.
and they think, you aren't serious people, or something, which is a problem also, because I mean they're trusting you with their health and their data, so it's really important to show up with your I's dotted and your T's crossed.
Absolutely. But from a measurement perspective,
your data's fine.
Your data's fine.
And then up to this will impact patient perception, may impact the future response, likely to impact data, but they'll be able to work it out all the way to I don't trust your data at all.
No.
And any data that you have is bad data, so you'd rather have no data, throw X out. It's not rocket science, but it is important categorization, and it hadn't been done. As far as we know, it hadn't been done.
Which was shocking, but I guess not, because some of the simplest things people just assume are there.
But it's a good approach for everything, especially when we are operating at such a scale, and the studies themselves are operating at scale, and then there's thousands of studies every year. So
do you think, though, so I'm going to turn the tables, do you think that hopefully if people would find this useful, do you think that it's going to be greeted positively by some, negatively by others? Will people be scared of it because errors are being pointed out? Even though everybody on the surface, obviously you want all your errors because you want your data to be good, but then you're also kind of judging people's work, which, you know, in all fairness, if it's not good, it's not good. So I mean,
I'm happy to have my work judged.
Well, it's your reputation too, right?
I think it's a good question. I think the answer to that would have been different a couple of years ago. And maybe that's why it didn't exist. Well, one, I think it didn't exist because this is the soapbox I've been on since the ECOA consortium the other day. People aren't publishing their failures. They're not publishing why their successes are successes, and they're not publishing their failures. They're not talking about failures. Being able to look and say, hey, there's this industry problem, and we want to throw some good people at it to figure it out is unique to a lot of things in this space. But more practically, I think that we are in a moment where AI actually does have the ability to solve for a lot of these things. It helps with quality checks. It removes the manual nature where there's 1,000 hands touching something, and so there's 1,000 opportunities for somebody to have good intentions and mess up the conceptual validity, you know, in the way that we've talked about. And so a lot of that's going away. And let's train AI to do that kind of evaluation with something that has been systematically developed. And that's in flight. So it's disruptive, but it's a moment of disruption. Is that right? Like, or I should say, I think it could have been considered as kind of an audit, a naggy situation, but there's something that can be done about it.
And I think, and again, this is more your field than mine. I mean, I've been on the periphery of that area just because of what I do, but never immersed myself in. Maybe before, 5 years ago, 10 years, maybe we weren't ready for it because we were still evolving, you know, all of the operational issues that have been going on. And we're, you know, as they just said now, we've been 15 years with ECOA at CPATH. And people have been using ECOA platforms for a very long time. Are we there now that we're working out the bug? We've worked out most of the bugs. Now we get to think a little bit higher level, and we get to think about, okay, how do we make this better? because before there was too many things going on, and although that good data is always on everyone's mind, you're moving fast because industry is moving fast, and so you can just do as much as you can do, but now you can kind of take a step back and allow yourself to look at your data, rank your data, and fix your data. For me, again, this being your field, I would wonder, when would you implement that? Would it be an audit check? Would it be a midpoint check? Like, what would that look like?
One of the things that I've socialized with some copyright holders is that they would love for it to be applied anytime one of their measures is being implemented. That would require the type of automation that we're talking about, right?
Yep.
I mean, when we were manually applying it, it was like,
It was hard. It was a lot of work.
Yeah, it was a lot of work, and it was a lot of, rater training, right? And I mean, that's the other piece of it. I think that because you and I come from a background where we are taking measurement so seriously that even when we're just asking people to look at something and apply our very simple 1 to 5 scale,
it's not rocket science.
we needed to do rater training. Like, we needed to measure for inter-rater reliability. We needed to go a few rounds and work out some kinks in how we were defining things so that we could be sure that multiple people from multiple functions were interpreting it the same way. That's not a step that a normal person takes when they're just trying to evaluate what we need to do about a problem. But it's something that people like us do.
But it's very
super
important.
It's super important.
And I also think that, just like your measure is never fully validated ever, this is a flexible moving kind of measure, in the sense that, version 1 will do what it will, but as time goes on and as technology improves, or we may have to modify what that looks like, or as we get more data and we analyze how the IMS is working in real life, or with large data sets, there may have to be continued changes. And I think that's what's exciting too, is that we're at the very beginning of thinking about it, but we could evolve it into, and I don't know what the answer is, but we could evolve it into something else.
Yeah.
And I love how you brought in AI, because I think AI is so important. It's here to stay. It's getting scarier as we go along. And you can't keep up, because as soon as you start thinking about AI and how we could use AI with our measure, then there's all kinds of other parameters or things that kind of come into play and that you have to take into consideration. When you were talking about putting into AI, we know now we have to check everything that comes out of AI. They cite incorrect sources. So I always think AI is like a research assistant. They're just giving you stuff, and you kind of still have to go through it. So with the measure, as AI evolves and we get access to better technology, as we teach it, I still think there's a human element that will have to be there at some point, where we're going to have to check the checker to make sure that everything is going. So I never feel like we'll ever fully, at this stage anyway, be able to take ourselves out of it, but it's going to make it easier.
Right. It makes it more practical to do the types of checks and balances that ought to have been done, but don't.
Yeah.
So let's move on to, what are you excited about? Either from over the last couple of days, what are you looking forward to in this space? Is there anything that...
Oh my gosh. I still think after 20 odd years of being in the field, I'm comforted in some regard by what we did 10, 15, 20 years ago is still very important, and it's still the bedrock, the cornerstone of what we do. I like the fact that we have evolved and narrowed in on certain areas, and expanded the way we think about it out of just the patient-reported outcomes to the ClinROs, to the patient-centered outcomes, and sort of looked at the whole field entirely, always with the patient experience data in the back of your mind. But I like now how we're kind of challenging things. We're thinking about experience. We're thinking about expectations. We're thinking about equity. And I think that's a real neat path that we can stop and take a moment and kind of think on. And not that we haven't done it separately before, but I don't know if we've done it together. And that's kind of what I'm excited about, taking this, continuing to move the field forward. It always does my heart good to see so many people and new people come into the field, and say that, wow, this is really interesting, or I never really thought about this before. And I've always said when somebody says to you, what do you do? And I said, how much time do you have?
Yeah.
Because it takes a really long time. But as I start to explain it, people will say, well, yeah, that makes sense. Well, yes, we know it makes sense, but I don't know why nobody's ever done it before. But now we have a much bigger field. We've grown and tripled in size, and more people are questioning what's happening. And I like the fact that we have these kinds of meetings, whether it's a CPAP meeting, an ISPOR, an ISAQOL, even meetings that, therapeutic meetings are starting to think about these things, that we're still trying to continue to push the patient perspective, patient experience, but people are listening. Regulatory is listening. Whether it's, FDA or EMA, everybody understands that we have to put the patient experience first. So I like that patient-centered outcomes is not just that anymore, it's patient experience.
Yeah.
And I like that we have that bigger, broader concept, and it's, it's not all, yes, getting it in a label is really important. Yes, getting it paid for and getting it out to patients is really important from a measure perspective. But understanding what's going on with the patient as well outside of that measure from an experience, and then learning how to incorporate that, I think is really kind of a neat thing. And I think I like how we've evolved in that regard.
Yeah.
Does that make sense?
It does make sense. I think that there was a comment that stood out to me, someone made, well, there were a couple. One was, we are all patients and we need to be looking at it that way, and I think that that's just a powerful way to be thinking of things. But another, it may have actually been the same conversation, but of course we're patient-centered at this point, right? Everybody understands the importance of that. Patient-centered drug development means looking at treating an indication, treating an illness instead of a compound-centered drug development. And that was really important. And it also freed me up to grapple with something that I've been thinking about a lot lately, which is that you can't be patient-centered without being site-centered at this point.
Interesting.
Yeah. Really? Have I not said that to you
No,
before?
you've never said that to me before.
I will not shut up about that.
Okay, well, you didn't tell me.
It keeps coming out of my mouth, and I'm hearing it, and I'm like, stop it.
No,
but
tell
it's
me.
so important because
Elaborate.
so much of what we're hearing is we've got patient training materials, all this stuff, right? And that's great. We've focused a lot on patient engagement and making more stuff to do that with. And I'm really, really glad that it exists. It's very important. But we're not empowering sites to explain to the patients what we're asking them to do and how to do it. The conversations that I have with people at sites, with people at vendors, kind of across the industry, is there's all these help desk tickets, it's called, right? But that's not data that anybody's doing anything with. And I even hear, or that's not fair to say, some people are doing things with it, but not systematically. But it's just like any other customer service thing, right? Like they're handled by customer service agents who are just looking to de-escalate your issue, not to ensure that the patient who has just had an infusion and finally has the energy to do, their PRO within the window that they need to be compliant, can't get the system to work.
Yeah.
So they're going to wait for the second help desk person to call them back.
Yeah.
You need to be site-centered in that way and not just kind of have people figure it out.
So when you said site-centered, that's not what I thought you were talking about at all.
No.
But your explanation absolutely makes sense. And we did talk about that yesterday, I guess, where they said we need to educate the sites. We can't just have them printing forms off a computer and getting them to fill out. I mean, that's the basic part of what you're saying.
Yeah.
But more importantly, what you're saying is having, you've asked that patient to maybe drive a certain distance to come in, and they have, chronic pain, they find it difficult to sit all the time, but they're coming in and you're asking them to participate in this study, which they want to do because they want to see improvement and they want to get their voice out, which is great. But is there somebody really, and I think in rare disease, you will find that the clinicians are more engaged with the patient because they know they're closer to the patient. At least I hope they are, because there's so fewer patients. But in general pop or in chronic conditions, and sites are just sometimes sites are just churning out. And it's not because the sites don't want to, is that they don't have the bandwidth to do
exactly.
it, right? There's nobody there. And in the old days, right, site monitors would come in and make sure the data was okay, but nobody's coming in to make sure that patient is okay.
Yeah.
And are the sites being given the opportunity to educate the patient, or is the company that's sponsoring or the CRO that's running it giving the opportunity to educate the patient as to why they're doing it? And I know that sounds like, oh my God, that's just more time for the patient to sit down and have a listen to. And I don't know if it has to be done at the site. It could be done on like a FaceTime or a call with the patient when they're home.
But see, this is what I'm talking about. Like, it's not. I don't think it's so much more time. It's just we're not being thoughtful about how we're using our time. And so if you look at the IM kickoff meetings and the SIV, like all of these things, there's so much time that is spent about ECOA. There's not very much time spent about ECOA, but so much of the time that is spent on ECOA is like, here's all of this stuff about our system and how it works. And there's not frequently this, when the patient comes in, you need to explain to them that these PROs are important and this is how they're used. Just kind of meet everybody where they're. It's basic behavioral science. People are more likely to be compliant and do what you ask them to do if they understand why it's important. If you're just being polite, right? I mean, it's just courtesy. But another way, right? I don't know what the latest number is. Last I heard, I think there were 19 different systems that sites generally had to log into for your average trial. So when you're hearing sites saying, how can we make your life easier? They're saying take away the tech. Or we could just be more site-centric in our implementation, in our rollout. Some of the sweeping under the rug of the IMS addresses and kind of brings out into the light, I've observed instances where they say, oh, well, we'll just tell the site to let the patient know what the order is in that question. That's incredibly site burdensome, and it's really bad.
Oh my God, that frightens me to no end.
I know. And then other things that are simple as we're working to make everything digital. I've heard sites ask, can we print out and laminate what we're supposed to do for each study, please? Just go back to the old days in some ways. Yeah. So I think we need to listen to sites because they also
they're on the front lines.
We need to let them be patient-centric too.
Yeah.
So I think that's what I mean when I'm saying we as patient-centric people need to be site-centric, because otherwise it's just two opposing silos.
But is it a pipe dream? I mean, nothing is a pipe dream, but I just think then, playing devil's advocate, somebody's listening to this saying, okay, that's lovely, but it's how are we implementing this? I mean, operationally, how is this implemented? So, and maybe it's not everything at the one time, so maybe it's a slow integration.
I think it's a slow
integration.
I
like your fact of, let's have, I know we're supposed to be paperless, but the lamination is always, can be super, super helpful. Or maybe it's a short video that...
Kelly, I got one.
Okay.
You're gonna lose it. So because one of the ways to do it, short videos, made me think, there's quick reference guides. I'm gonna be presenting on this at one of the conferences later this year, but I've got data. When we are doing our training reviews and looking at the quick reference guide, so the only one that somebody's going to be looking at, the 2-pager instead of the 400-pager, the information's wrong.
Oh my God.
Inconsistent with the big, right? So that's
how does that get through though?
It doesn't when we look at it. But when teams like ours aren't engaged, just nobody's looking.
Yeah.
So that's what I mean. There's a huge, lofty, beautiful blue sky situation, and I mean, can we just give them correct information?
Okay, so that's first.
Accessible?
Correct information first. Maybe laminate second or short video third. But I didn't even go that far. So and silly me, I should have really thought.
Yeah.
It should be correct, because again, the IMS is all about, let's just change this word because I think it sounds nicer, or I don't really like that. Maybe the response options need to be changed, or something that we think it's horrific for us, but people, oh, it's not going to make a big deal.
Right.
And what you said about, oh, well, just tell the site to tell the patient. Like, oh my God.
Oh my God.
Like, A, who's documenting that, and how do we know it's happening, and how do we know it's consistent, and oh, yeah.
Yeah.
That's kind of a frightening.
Okay, so
Frightening matter.
last topic that
Okay.
we talked about, departure from this stuff.
Okay.
What are you listening to? We were saying, I'm a big Amy Poehler podcast fan, and I wanted to add a little bit of, I wanted to steal from her. And so she often asks her guests what they're listening to or reading, what's making them laugh. We can be a little nerdier than that. It can be how you escape,
Yeah.
or it can be some nerdy thing, whatever.
Yeah, I'll gotta go with how I escape,
Okay.
because I feel I do nerdy things all day long. I do like, and we talked about this yesterday, I do like crime, true crime, or crime dramas. So I don't know why, and I think there's some psychology behind it. And it's not just me, although I did think it was just me, but then I heard it wasn't. Having it in the background, I can listen to shootings and police sirens and all of that sort of stuff, and be very relaxed about it. And I don't know why that is, but
Can you watch it?
oh yeah.
Okay.
Oh well, I can watch certain things, but sometimes I have to watch through my fingers because.
That's how I've been watching The Pit.
Oh really?
Are you watching
Oh,
that?
I love The Pit. Oh, I love The Pit. Yeah. No, I mean I love The Pit. I love the docuseries that come out about on Netflix that some major crime that's happened,
Oh, yeah.
or like Church of Scientology, or the fundamentalists, or just any of those kinds of things. Or yeah, I love the documentaries because there's an element of, oh my gosh, what's happening. But like the driving, I like the true crime
Yeah.
podcasts.
Yeah.
I told you about one that was
Scamanda.
Like that blew my mind,
Yeah.
because how can that actually happen? Yeah, so for me, those are kind of the fun things to kind of turn my brain off. While I still maybe learn something as
Yeah.
I'm kind of listening.
Yeah.
So yeah, but TV-wise, I think The Pit is one of our favorite shows, and my husband and I watch a lot of Taylor Sheridan stuff, like so Landman and
I have not heard of that. I will need to check it out.
like Yellowstone. You've heard of
Oh, I've
Yellowstone.
heard of
Okay,
Yellowstone.
so Landman is based in West Texas, and I lived in West Texas for a while, so it's kind of interesting to sort of see, or I guess the panhandle of Texas. It's interesting to kind of see the topography, and oh my God, I remember being there, and but really, really good show.
Yeah, you are not alone in your true crime love at all. So
What's your favorite true crime or what's the one that you listen to that, besides Scamanda, because we talked about that you went, oh my God, I can't believe that happened.
I just finished The Idiot, and
You
that
told me
one was
about that,
pretty good.
right, okay, yeah,
Yeah,
yeah.
and it's short, and I like kind of the serialized ones, but I find that true crime gives me the right amount of rage when I'm working out or cleaning.
Yeah.
Because so I will do like True Crime Obsessed, or my favorite murder.
Entertaining is also, I feel wrong saying it's entertaining because it's sad. So will we call it educational, or will we call it, I don't know how to, I don't know how to describe it, because I don't want to call it fun.
No.
Because it's not. Educational, maybe.
I think that it's always
Informatic,
interesting
I don't
to learn about people who are operating at the edges of society too. So that's how I justify
Interesting.
it. Yeah.
Interesting.
Yeah.
We'll go with that.
All right. Well, thank you for sitting down and talking.
You're
to me.
welcome. Anytime. It's been fun.
It's been fun. Are you going to ISPOR or Isaqual or other ISPOR?
Yes. Yes. I will be at ISPOR in Philly, and then I'll be at Isaqual in Prague.
All right. Well, maybe we will do one of these from one of
That
those.
would be fun, in a fun location, like a historic background.